Thank you so much for having us here today. I'll be talking about some updates. I'm a rheumatologist. My name is Mohamad Bittar, and I'm very happy to share with you that I just got promoted to associate professor last month. Thank you, and I'll be talking about a lot of updates of what we've been doing for the past year. First of all, of course, I have to thank my mentors. I know I'm biased, but I think I have the best mentorship team ever. Thank you so much, Jennifer, Yvonne, Rick, Dan, Tom, Atul, and Mary. Those are amazing mentors, national experts in their fields, and I'm learning a lot from them on a weekly basis. First of all, of course, I'm going to be talking what I do is I study chronic pain mechanisms in axial spondyloarthritis. But for the new people in the room, what is axial spondyloarthritis? That's important to know. This is a rheumatologic inflammatory autoimmune condition that affects the spine. It starts in the sacroiliac joint, and it can affect the spine. It can cause a lot of debility, pain, and of course, fusion of the spine. If you have not heard about AxSpA, please help us spread the word so we can diagnose this early. Patients usually present with inflammatory type of back pain. They have a lot of morning stiffness, a lot of low back pain that gets better with activity, worse with rest. We do not want to miss the diagnosis because we have treatment that can prevent this from advancing and progressing. Sadly, up to 50% of patients develop chronic pain who have AxSpA. We have powerful biologic treatments that we can control inflammation, but still they can, up to 50%, develop chronic nociplastic type of pain. At this point in the clinic, we say we do not know where this pain coming from. So that's what we're trying to study is what is the origin or the cause or the etiology of this chronic pain. Of course, the aims of this project has changed after I met with the mentorship team. The aim number one after the modification is to evaluate cross-sectional correlation between functional brain connectivity and clinical measures of pain, mainly widespread pain index. And the hypothesis is that there is a positive correlation between the default mode network and insula connectivity and clinical pain scores. Aim number two is to evaluate the cross-sectional correlation between brain activation by a visual stimulus. This visual stimulus actually was found here in Michigan, which is the checkerboard stimulus. We implemented it in the MRI scanner that we have at OHSU, and we correlated that with the clinical measures of pain. So hypothesis is that there is a positive correlation between brain activation and clinical pain scores. Aim number three is patients, of course, we follow them over time. We treat their active inflammation, we control it. And then we have two groups at the end, a group that has active pain without inflammation and a group in remission. And these patients, we are going back to their baseline fMRIs to see the differences if we can predict who will develop nociplastic pain features in the future. Of course, we're not at that point yet, but we're working on it at this point. Progress, we've had a lot of progress. Of course, we started in July 2025. I've met with my team, with the mentorship team to discuss the project, modify it. We got IRB approval in mid-December 2025. We did not wait a lot. The first patient was recruited within a week of the IRB approval. Our target sample size is 75 patients. So far, we have 45 patients who got already study procedures and finished they are enrolled. So that's 60% of patients within 6 months of IRB approval. We have 10 patients who are already recruited, and they will complete the study procedures within the coming month or two. So we are working very hard to enroll everyone as soon as possible. Also, we have a nociplastic pain cohort ongoing. This is a QST cohort, QST-only cohort without fMRIs. We have more than 100 patients enrolled so far. This is partially funded by the HEAL K12 and partially by the Spartan Foundation. We have prelim analysis, which I will go over, that we did in June 2026. I submitted 6 abstracts to American College of Rheumatology. This is the highest number I've done so far. And 2 abstracts to an international congress that I will present next month in Belgium. So prelim data, first we start with aim 1. This is baseline characteristics. I'm sorry if this is not very clear. But this is prelim data on 31 patients out of the 45 that completed their study procedures. Mean age around 38, which is expected for AxSpA population. course, we collected a lot of data on sex, on race, on BMI, current smoking status, alcohol status, drug use. Only 19% had a history of confirmed or diagnosed fibromyalgia from before. Of course, we collected data on their genetic background, HLA-B27 status, on disease manifestations, on pain scores, including widespread pain index, PROMIS-29. Thank you, Dave, for teaching me about PROMIS-29. Anxiety, depression, fatigue, and medication use, including opioid. We've been doing good. Only one patient was on opioid, which is great because we always argue that we do not want opioids in patients who have axial spondyloarthritis. So aim number one, we try to plot the connectivity, DMN anterior insula versus pain scores. And we see very nice correlation between anterior insula DMN connectivity and widespread pain index. These achieved statistical significance with the prelim data that we have. Also, it correlated very nicely with BASDAI scores, which is an AXPA score. We ask patients about their level of pain, stiffness over the past week, and so on, and with the current pain scores. So we have seen this correlation, and hopefully we will continue to see it once we recruit the full sample size. Aim 2 and 3, of course, Aim 3 we could not do the analysis for the last part of the Aim, but for the Aim 2 visual stimulation, we saw very nice results, an activation in the anterior cingulate cortex and in the posterior middle temporal gyrus compared to patients who do not have pain. So we stratified them based on pain, no pain, based on their fibromyalgia survey questionnaire, also based on current pain score and based on BASDAI scores. And we had 16 versus 15. Of course, this is prelim analysis. And we found statistical significance in the activation of the ACC and the PMTG, which are areas that are involved in the pain processing and emotional cognition of pain, and PMTG is involved in rumination of pain when patients fixate on pain symptoms. Same, we did separate analysis. Thank you so much, Rick and Apeksha, for the help with this type of analysis. In patients who had pain, in the pain group, we saw a correlation between activation in the insula and PMTG and between the clinical pain scores. So these are very encouraging results that we will continue to build on for the future. We have exploratory aims as well. So we are doing visual stimulus in the scanner. This visual stimulus in the scanner, it gives a stimulus at a pre-specified intensity. But also we are interested in looking at quantitative sensory testing to see if patients have different types of threshold. So I was like, how can we do that in the clinic without using a checkerboard? And how can we identify specific thresholds for every patient? So I looked at this visual photosensitivity testing using ocular photosensitivity analyzer, which was developed at the University of Miami. From my understanding, and maybe Dan will correct me, I have not seen this studied in rheumatic diseases before, like rheumatoid or AXPA. So probably this is the first study in rheumatology to be done, of course, in rheumatic inflammatory conditions. It's very interesting where we ask patients to rest their head on this machine. It's similar to what ophthalmologists use. And then the machine will shine a light at different intensities to the eye. And then the patients will have a button. They will press on it whenever they feel either pain or aversion or distress from the light. And at the end, it will give us a threshold. Every patient will have a different threshold. So this is similar to what we do if you want other quantitative sensory testings, but it will bypass pressure on the joint. It will bypass operator dependent that we have with algometers and other types of methods. And we did some analysis on it, and it was very interesting to see that we saw a very nice correlation between visual photosensitivity thresholds and fibromyalgia survey questionnaire. And the interesting thing is that we did analysis based on fibromyalgia survey questionnaire, which is more widespread type of pain, and current pain score, which can be low back pain, localized. We saw correlation with the widespread type of symptoms, but not with the localized symptoms. So this could be a nice method that we can use in the future for objective measure for nociplastic type features. I'm gonna definitely continue to study this for the future. This analysis was done on 30 patients, prelim, and of course we're continuing to enroll more and more. For the nociplastic pain cohort, I know Yvonne is not here, but Yvonne taught me how to do these quantitative sensory testing. And now, believe it or not, I'm teaching people how to do it, which is very interesting. We have more than 100 patients in this cohort. This analysis was done on 83 patients, and we saw a very nice correlation between fibromyalgia survey questionnaires, widespread index, and with the PPT's pain pressure thresholds in the trapezius, in the sacroiliac joint, and in the knee. We've done, the PPT is using the algometers, temporal summation using Neuropan, and CPM is using water bath. We did not see any CPM differences, statistical differences between the groups, and no correlation. The interesting finding is that we saw very nice correlation between fibromyalgia survey questionnaire and the ASDAS-CRP. ASDAS-CRP, we thought about it as the most objective measure of disease activity in axial spondyloarthritis. But it turns out it's very subjective. It's contaminated by nociplastic type of pain features. Now I'm trying to push the spondyloarthritis community to look at other measures that are more objective of inflammation. I do not want patients to get biologic treatment because of an ASDAS-CRP that's not measuring objective inflammation. This is very important. What's next? Lots of things to do, of course. For the HEAL K12 to continue to enroll patients to achieve the full sample size, submit a K23 in October in 2 months. I'm working very hard with amazing group of mentors. Thank you, Dan, for all the help. Yvonne, Rick, Marco, Ramon, and Atul working with me on a daily basis. Thank you for keeping up with all my emails and questions and requests to submit a very, hopefully a nice K23 application. And I have a PWLE advisor on this study. So that's a great thing. I'm learning from the K12. And the topic is to study glial activation and neurochemical imbalance as possible mechanisms driving chronic pain in patients with AxSpA. Of course, this will be, I will connect it with what we found as part of the HEAL K12 to advance this field further. That's not it. I want to acknowledge my friend and colleague, Dr. Ravyts. We put together a very nice grant application and we submitted that 2 weeks ago to Spondylitis Association of America. Actually, the HEAL K12 is amazing for the new scholars. Make the best out of this opportunity. Meet amazing collaborators. Before the HEAL K12, I had no clue anything about psychology. Everything I knew is CBT, cognitive behavioral therapy. And I chatted with Scott maybe a few months ago in Philadelphia. I was like, can we do CBT study? He was like, what do you mean by CBT? I was like, CBT. He was like, okay, there are lots of different types of CBT. I was like, okay, educate me. And he told me about different types. And then, of course, thank you, Drew. Thank you, Dan, for being our advisors on this study. We're trying to study brief pain reprocessing therapy in AxSpA. We'll hear about it tomorrow from Drew, of course, but we're trying to study it in AxSpA, which will be the first study in rheumatology, hopefully, to study this type of mechanism. We'll let you know once, hopefully, if we get it, if we get the grant, but I have high hopes, hopefully. And I would like to thank the amazing team that I work with, research coordinators, data analysts, students, and the funders, which, of course, I'm not able to do anything without their support. And thank you.
Hello, lovely presentation. One of the things as I am both a PWLE and a researcher, and I do trans health research, and we are seeing a lot of information about higher rates of joint diagnoses in the trans and gender diverse community. A big piece came out last summer in LGBT health. I'm wondering if you were, particularly AxSpA is one of the main conditions that we are seeing at really high rates amongst trans folks. I'm wondering if you are collecting gender as compared to sex as an option as well, and if you have seen any trends in that.
Yep, thank you. This is a very important question. I definitely see a lot of transgender patients in my practice. I lead an AxSpA practice at OHSU. It's a very specialized clinic, and I have a very good, sizable population of transgender patients. Yes, we are collecting this data, including gender. I can tell you clinically versus research. Research, I do not have the analyzed data to support it, so I don't have the evidence behind it. But clinically, I'm seeing increased rates of joint pain, low back pain, type of similar to axial spondyloarthritis in transgender patients, especially female to male, because of the testosterone. Uh, Theoretically, historically, axpa is more common in a male population. And if we talk about the more advanced form, the progressed forms. So probably there's some association between the hormonal changes and the induction of this disease. This is something I'm keeping a close eye on. I'm having a clinical observation, but I need, of course, to support it with research findings. But thank you for letting me, a very important question.
If you ever want to collaborate, you know where to find me.
Hi, my question is how difficult, in your perspective, does it seem to get the diagnosis spinal arthritis?
Yes, that's amazing question. Thank you. So in my other life, I know I'm a researcher here. My other life is I'm an educator. I do a lot of national education on axial spondyloarthritis. There is a delay in diagnosis of average of 7 years in this diagnosis. It can go up to 14 years. Patient can get fused because they see providers, they do not know what they have, and they tell them this is growing pain or this is the whatever pain, you know? So we try to educate a lot. Symptoms help a lot in knowing whether to think it's degenerative versus inflammatory. You know, back pain is a symptom. It's not a diagnosis. And this is what we try to tell provider. Do not label it immediately until you know what is driving this type of symptom. So if it's more sounding like inflammatory, it will deserve further workup to know if there is inflammation or not driving that. If it's not sounding inflammatory, it could be degenerative, neuropathic, coming from a bulging disc, or so on. So clinical history is extremely important. That's why it's important to spend time with patients listening to their complaint or to their symptoms. And the next step is how to work up the condition. And this is important to educate providers because if they do not know the condition, they will not refer patients, they will not do workup. But imaging play a big role, including MRI of the SI joint or the lumbar spine, of course, X-rays, to see if this is inflammatory or this is mechanical. Great question.
Hi, I have a couple questions. For the K23 study, are you using any advanced neuroimaging to map glial cell activity and act as proof of structural or metabolic pathology?
Yes, great question. Yes, we are planning to use PET MR imaging, which thankfully I have access to at OHSU. It's not available everywhere, but it's going to be a very expensive study. We're trying to work with the mentors on reorganizing the study a little bit. But yes, it will involve both PET MR imaging and MR spectroscopy as well. Things I do not have expertise in, but I'm looking for the opportunity to learn how to incorporate in my studies.
Oh, that's really exciting. Also, for the nociplastic pain cohort, what were the, maybe that's not the right word, but the recruitment qualifications to decide this group of people has nociplastic pain just because it can be confounded by so many factors?
Of course. So we are actually recruiting all AXPA patients that they are willing to enroll with us. And we are following them over time. We're giving them treatments. And then we follow in 6 months, see if the inflammation is gone, if not gone. I have objective measures where I do repeat an MRI of the sacroiliac joint to see if there's truly still active inflammation or not. And we're collecting clinical scores like fibromyalgia survey questionnaire, widespread pain index. And then we are stratifying them as having nociplastic pain features or not. Basically, I have a long list to look at to see if there's any inflammation like blood work, imaging, active swelling or things like that. And then if everything is negative, then they will be in the nociplastic pain bucket if you want.
You knew I'd ask a question. I have to acknowledge that Mohamad is my mentee, and so he knows probably what I'm going to ask. Can you take those charts, which when I looked around at PWLEs, their eyes were glazed over. Can you take those charts and tell us what it means to a person with pain?
the chart and the
All the
graphs.
scatter plots and whatever. Yeah, translate it down so I will understand.
Of course, I would love to do that. Sorry if it took me more than 15 minutes, that's fine. It's not an Ames page. Ames page, we need to stick to the one, one page, but now we can go beyond 15 minutes. So let's go back to do it. Okay, so the insula is part of what we call salience network. This salience network, theoretically, it should get activated if we have an incoming input or insult, like a painful insult or so on. Default mode network, from the name, it's default mode. It's by default, it's active if we are relaxed. If we get any input or insult, it should get inhibited so the other parts of the brain can modulate pain symptoms. But so if we see a lot of connection between this insula and the salience network and the default mode network, that means they are not working as they should be. So both they are being functionally activated together. And that means the brain is continuing to focus on a chronic pain state instead of modulating the pain to inhibit it. And that's what we are seeing. The more they are connected together, the more the clinical pain scores are higher. Or the patients who have higher pain scores, they have more connectivity. So there is something in the brain that can explain why patients go into chronic pain state. So it's not okay to tell patients that you have secondary fibromyalgia, that we say it, you know? What does it mean in this case? Explain to patients that, yes, there is something actually organic happening in the brain that can explain why they have symptoms. And by, of course, finding the etiology, we can hopefully target it later on so we can develop improvement and a quality of life for patients. Of course.
Thank you. Great talk. I missed when you were presenting the photosensitivity QST. Who are you excluding in this? Specifically, I'm thinking migraine patients, but I'm curious about, are there any other populations that you're having to exclude when you're using this measure?
Actually, we're not excluding migraine patients. Even seizure patients, we're not. The thresholds for this OPA were studied as a safety measures, and they do not induce migraine or seizures. This is different from the checkerboard stimulus that we do in the brain scan. It's a much higher frequency where we exclude patients with migraine and seizures. So for this study, we mainly exclude patients who have active advanced eye disease, which can be very sensitive. Like if they have active uveitis, of course, I do not include them. Uveitis, they have active inflammation in the eye because the eye will be super sensitive. Certain types of eye conditions like advanced glaucoma as well, we cannot include these type of patients. Any patients who have history of neurologic damage, like certain traumatic brain injury, of course, we cannot include because that can confound the findings. But the thresholds that we use for this OPA, we do not exclude too many things, which is good.
Thank you.
Okay, thank you.
Sorry. Thank you. Just on top. Okay. That'll teach me to have a long password. Hello, everyone. Thanks for participating in my ongoing public speaking exposure project. Okay. Thanks so much. I'm really excited to be here today and to meet many folks and see many folks again. I'm excited to share some updates to our project looking at pain prescribing guidelines and their impact on outpatient pain management for youth with sickle cell disease, primarily those with chronic pain. I'm really delighted to be supported by an amazing team of mentors, many of whom are listed here, who have been really engaged throughout this process, and I really appreciate your support, as well as the larger community here. I'll give some updates that I've made with the support of my mentorship team to the K12 project, and then some updates I've been doing on myself. Folks in here may know about sickle cell disease. We had Dr. Martin talk to us about this earlier as well, but I just want to level set. Sickle cell disease describes a group of interrelated blood conditions that result in changes to the shape and functioning of red blood cells with many effects throughout the body. Pain is one of the most common complications associated with sickle cell disease, and it starts really early in life. About 1 in every 2,000 newborns are diagnosed with sickle cell disease, and almost 3/4 of youth with sickle cell have had a pain crisis by the time they're 2 years old. In many cases, the frequency and intensity of pain crises can increase with age. Almost 1/4 of youth with sickle cell disease may also have chronic pain, which can persist for months on end and occur on most days, if not all. People with sickle cell disease are known to receive inadequate pain care, and there are a number of factors contributing to this. We know that the majority of people with sickle cell disease in the United States identify as Black or African American. We know that forces like structural racism that exist outside of a patient-provider relationship can influence the way that people receive care and resulting healthcare disparities. And we know that some of the mechanisms that might contribute to this are stigmatizing beliefs about sickle cell disease as a chronic condition, about folks who experience pain regularly, and about folks who use medication or other approaches to treat their pain. We also know that there is bias in relationships between providers and patients, and between relationships between patients and the system that they're receiving care in, that can affect the way that they receive care and the impact of that care. And we also know that challenges in actually accessing the care that they need, even if, including many of the folks in this room, really great treatments are being developed out there, there can still be challenges in actually receiving those treatments. I want to give you a few examples. We know that opioids are part of adequate pain treatment for people with sickle cell disease and are used both in acute and chronic pain treatment. But we also know that people with sickle cell disease are not more likely to die than other individuals who are receiving opioids, such as folks with migraine, low back pain, and fibromyalgia. That being said, beliefs persist, and one of the most common stigmatizing beliefs about sickle cell disease and about people with that condition are that they are seeking out opioids on purpose. We also know that there are many potential or practical access barriers that youth with sickle cell disease may encounter in the healthcare system that can really limit their pain management options. For example, as a person on a multidisciplinary team and a psychologist, we know that we can't actually bill insurance for the time that providers spend discussing with each other, which can really get in the way of having multidisciplinary pain care. We also know that insurance will often refuse to cover continuing care. So for example, someone might go to physical therapy, and then they might want to get referred back to physical therapy to continue working on their chronic pain. And insurance might say, well, we've already approved treatment for that condition, we're not going to approve it again. Some providers in this room who are prescribers might have also experienced this idea where you think you know what kind of pain medication this person might benefit from, but something called step therapy prevents you from prescribing that medication before you prescribe something else that the insurance company has decided that you should try first. As a result, youth with sickle cell disease are impacted by multiple intersecting stressors at multiple levels. So we know that they're experiencing structural racism in the context of receiving their care that might lead to assumptions about who they are and what's important to them. We know that they're experiencing pain, and now we also know that they might be experiencing low availability of pain care. They can't even get the things that might help them manage their pain. So our goal for this K12 project is to inform policy at the system level that promotes adequate pain care for youth with sickle cell disease, especially folks with chronic pain as well. But in order to get at that goal, we need to understand what's getting in the way. So if we think about our outcome as a policy solution that would improve access to pain management for youth with sickle cell disease, we need to know what the barriers are to that adequate pain management in order to inform that policy solution. We need lots of different types of information to get at that, which are the primary aims of the K12 project. We need to understand the lived experience of actually accessing pain management for youth with sickle cell disease and their families. We need to know what the trends are in prescribing medications for pain and in accessing referrals. And then we need to know, are people actually filling that medication? Are they actually going to that provider and receiving that service? In order to know that, we need a larger framework, which we've worked on so far. So that's in bold. That's something we're working on currently. We've identified some relevant prescriptions and referrals that we should focus on in order to understand what's being prescribed to folks. And then our next steps here will be to assemble a community advisory board and to work with them to develop interviews so that we can better understand the lived experience of accessing pain management. And then on the more quantitative side of this project, to integrate our institutional data and the health record with community data from a larger scale surveillance project called the Georgia Sickle Cell Data Collection Program, and then ultimately analyze those to better understand trends in prescribing and referrals. I'd like to really thank my advisory committee for always throwing me out that line. And I want to talk about some of the really important improvements that we've been able to make to this project as a result of their input. We're now including a greater variety of medications and referrals. So as a person who's not a prescriber myself, I'm really relying on our medical physician collaborators and folks who actually take these pain medications to help me understand what are the different things we need to include here, even those that might be off-label for pain management, as well as referrals to different therapies like physical therapy or behavioral pain management that might be important to include. They've also helped me establish some really important partnerships with collaborators across disciplinary boundaries, as well as understanding other folks who might be important stakeholders in this work. We've planned many what-if analyses because we know that real life doesn't always match the specific inclusion criteria or the specific situation that we think might be happening. And then we've expanded a planned community advisory board to include folks like people who are involved in insurance verification and billing, and perhaps even legislation as well if they're willing to be involved. So I want to share a little bit of what's been going on since we started this work. So some things that have been really important as supports for me are leveraging existing collaborations. So I've continued work in my PI, Dr. Sill's lab, to continue work on the intervention side of things. And then that has really led to some important collaborations that have helped me to develop this work. Facilitated networking. I am really benefiting from the amazing connections that I have on the mentorship team to help me understand, who are these other folks out there who might have important input for us to consider and who I might need to talk about in order to continue to develop this work. And then, as I mentioned before, having a really engaged group of mentors really makes a difference. These are people who I can see are really committed to my professional development and are helping me move along in this project as well. Some of the challenges have been that I'm new to health policy research. So as I'll share in just a moment, I'm pursuing a master's degree in public health in order to help me develop some of these important skills. Partnering on a protocol. So Todd and I are working together to develop this work. That's something I haven't done before, as well as sort of leading a team toward a research goal is something that's new for me. And then there are many, many legal and regulatory hurdles, which I will detail, in great painful detail to you at any point in time if you would like to hear about them. I want to give a little bit of update on what I've been doing to update myself. So the larger issue for me here that I want to make sure to investigate in partnership with my team is what are the system level barriers for youth with chronic sickle cell pain? In order to do that, I need multidisciplinary pain science training, I need policy impact training, and I need to know how to communicate and advocate. Overall, this is toward a research goal of understanding what system level changes will support equitable pain care for youth with sickle cell, and a career goal of a bidirectional pathway between pain policy and actual direct pain care. In the future, I hope to maybe conduct simulation or cost utility analyses to test what a policy recommendation would look like in real life. And then the pie in the sky for me is, can we standardize insurance coverage? Can we regulate them and mandate that they cover non-pharmacological pain care in the same way that they do for pharmacologic pain care? To help me learn about pain science, I presented a great opportunity to present a poster and a presentation with Todd this year at a couple of conferences to talk about partnering with a person with lived experience and about what that work has led to. We're currently working on a manuscript focusing primarily on opioid prescription changes after the 2016 CDC opioid guideline, and we'll integrate that with information about actual filled prescriptions by linking with that community data. From a health policy perspective, I just finished 2 out of 4 semesters of my public health degree. Thank you so much. It is a long haul. And I'm currently doing some clinical informatics training to better understand how to extract information appropriately from the medical record and what it means. And then I'll be continuing with this next semester in the fall. From a science communication perspective, I was really honored to give an invited presentation at a sickle cell echo or community learning collaborative meeting this past July about barriers to pain management. I'm currently on the United States Association for the Study of Pain Advocacy Committee, where we recently led an effort to increase engagement with the Federal Register to comment on recently proposed changes to the Office of Management and Budget Regulations. And then I'll be working on an opinion editorial about barriers to accessing pain management for youth with sickle cell and chronic pain in advance of our Georgia legislative session starting this January. Just some of my other work to share with you all. This is my brother and my mom. This is my brother and my sister-in-law and me. And then this is my dog, Cora. We just spent some time at Sweetwater Creek State Park this past weekend. This is her at her favorite coffee shop. Whether it's closed or open, you're going to find her there. This is my amateur rollerblading group, and then this is my soccer team. Thanks so much.
Hi, you know me, I'm Kadeem.
Hi, Kadeem.
I live with sickle cell beta 0 thalassemia. I really like your work, and you're looking at young children with sickle cell disease, but I wanted to ask, do you see any differences in genotypes with chronic pain?
Yeah, that's a great question, Kadeem. And I just want to share to the room that a real problem that we have in sickle cell disease research is that genotypic variation in studies is really uncommon. So often we see studies are primarily focusing on folks with an SS genotype, for example. We might not see as much representation of folks with other genotypes. And I actually just read a paper where we didn't really have much genotypic variation, which is challenging. So my hope is to be really broadly inclusive because the sickle cell program, the comprehensive program at Children's Healthcare of Atlanta, where I work and do my research, is one of the largest in the nation. That means we have about 2,000 patients, which is a pretty large program for sickle cell disease in order to focus on. And my hope is that as a result of that, we'll have some pretty wide variation. So anecdotally, what I would say is that pain seems to look different when I talk to kids. I think what we hear, and I just want to emphasize this as well, I think there's a common misconception that a SS genotype just means more severe always. And I think that's a really damaging misconception because there are so many different genotypes of sickle cell disease with different complications and different life experiences. So I think it will be important to continue to learn more about that.
Thank you.
Thanks.
Firstly, you are an excellent public speaker. And whatever you're doing to learn about science communication is paying off, because that was a very accessible, plain language, and also, deeply interesting presentation. So I just want to start with that. As a methodologist, I'm interested to hear a little bit more. It seems like you're doing some kind of mixed methods stuff. What is your kind of theoretical framework? I know we saw like the policy framework. How are you mixing your methods? Because they're from two different piles of information. It seems like you're not interviewing the same people. Are you trying to do kind of a sequential exploratory process, or how are you thinking about the mixed methods piece of this?
Yeah, essentially my hope is that because right now we're doing the analysis on the prescription data, that doesn't involve any sort of qualitative aspect. It's really just looking at the medical record and trying to get a sense of what the trends are. So my hope is that it will be sequential exploratory in the sense that we're starting to get some preliminary trends out of the analysis. And then as we're developing in the interview guide this fall with the Community Advisory Board, I hope I can share with them some of the preliminary findings of this quantitative analysis, and that will help to inform the interview guide so that we can explore some of what is involved there. But I think from a phenomenological perspective, I'd just like to know from the Community Advisory Board what are other ways we can look at this phenomenon of barriers to accessing pain management.
So that sounds like a sequential explanatory, though, if you're explaining asking people to explain what they saw in the data.
Yeah,
so
I'm hoping
let's chat. I would love to chat with you about it, because
yes.
My mentor, Mark, had never heard about mixed methods, and I think a lot of pain scientists don't get training in what it means to actually mix methods. It's not just bringing in qual and quant, and so I'd love to kind of hear what your thoughts are.
Yeah, thanks so much. I'd
that.
love some more guidance on how to explore the nuances of that, to maybe combine some explanatory, but also some more exploratory of things that might not be captured in the medical record.
Yeah, and for those interested, UM has an amazing mixed methods certificate you can take all virtually, so if you're looking to learn.
Awesome.
But really great presentation.
Thanks so much.
Since so much of your work focuses on barriers to care, and there's a lot of like higher level barriers that you're considering, for example, with respect to insurance, have you thought about some like downstream barriers, like inability for patients with pain to go to the pharmacy and get their prescriptions, or with controlled substances, the dance that people have to do, going from pharmacy to pharmacy to pharmacy and never being told ahead of time where they can access those prescriptions.
Yeah, thank you so much. That's really important. I think it's really difficult from a quantitative perspective to track those in the health record or in Medicaid claims, which is primarily where the community data is coming from. So my hope is that the qualitative aspect of this study and working with the community advisory board, that they might be able to help me make sure that I'm covering those sorts of areas. Certainly getting to the pharmacy and then challenges at the pharmacy just with supply and being able to get that. You got to the pharmacy, but they don't have that medication that you need. And some of the dosage like origami Tetris that needs to happen at our clinic in order to make sure that folks get the medication they need, even if it's happening in a totally different dosage, I think are things that I've seen anecdotally and that I hope we'll be able to flesh out in the community advisory board discussion so that it makes it into the interviews.
I got you, Jen. I'm going to make sure we have some
Thank you,
community
Todd.
health workers, including myself,
Yes.
as a part of that. And that's
Yeah.
something we look at. When I was a part of the Children's Sickle Cell Foundation of Pittsburgh, we actually look at providing resources for our families and individuals that are seeking, SSI, disability, resources for their medications, for if they need them picked up. Whenever we have any family members that are in the hospital, we'll actually go get their homework and things like that from the school to make sure they're accommodated, so they can make sure like 504 plans, IEPs and things are in place. However, if there's ever a time in which they need help with prescriptions or things like that, we can also look at, working in collaboration with their social workers along with their community health workers to make sure they have the necessary resources to get those accommodations and accessibility to the care they need. So that's definitely a great question, and it's going to be a part of a big portion of us trying to get our community advisory board together. So thank you.
Thank you. Really well spoken and well presented. I'm going to be the downer and just, remind you of the world that we live in. And, you mentioned looking to apply for a K. And so I'm just going to, take this moment to sort of remind everybody in the room that when you're presenting your data here, when you're thinking about the data that's being presented, think about how you can frame it as solutions oriented with measurable health outcomes. And those are the buzzwords that we're going to keep harping on, and I think are important to sort of integrate now early. And so it can, you're getting all this fantastic data, and we're seeing these observations, and it's all really valuable foundational research. But there has to be more right now. And so, I encourage everyone, and I think this is a great place to try to bring the patients in and try to think of what would an ultimate intervention look like? What would the solution be? And sort of find that way to connect what you're observing to what that outcome, that intervention would ultimately be. Because now, we're going to have to force you to go, 6 steps beyond what you might be comfortable with at this time. Mm-hmm. But just to make sure that we're keeping that in the back of our minds, because this is all fantastic work and super important. We just have to work on our framing.
Yeah, thank you so much. That's a really important point. I like to think of the study as a really big white paper, in the sense that, the information we're gathering is that big meat of the white paper where we're talking about the background, the rationale, what the problems are. But the point is to get policy solutions. The point is to inform policy change. And my hope is that by including at least one legislator or staffer in our community advisory board, that we'll be able to hear about how we need to frame and disseminate the results in order to inform policy more appropriately. Most of the time, in my experience, when I'm talking to legislators, they do want to hear from their constituents, actual patients who are experiencing these things. And my hope is that by including both quantitative and qualitative aspects, that we're going to hit the folks who are looking for data, and we're going to hit the folks who are looking for patient narratives when they're thinking about formulating policy, that our ultimate goal is going to be to include more insurance regulation. And we have some bills in Georgia that were introduced last year that we're hoping to focus this big white paper on.
Yeah, no, I think you're doing a fantastic job. I kind of just wanted to take the moment to bring us back a little bit to, because
you may not be able to use the word policy on your AIMS page.
yes,
Okay.
your AIMS page and your
To be clear,
Yes.
I'm going to be more
I-
direct.
Okay.
I defer to Dan.
Is able to be.
Fair enough.
Okay, policy, go. You can strategy.
Okay.
Strategy's fine, right? But policy sounds as though you're doing research with the intention of an entire office policy got nuked because of the word policy. So again, we feel terrible having to be the ones that are telling you this, but this is just the world we live in.
Yeah.
And so everywhere that the word policy is, again, in certain settings, you would just have to be super careful, unfortunately, about. But again, I think it's just we're all learning this, that we just have to use different words and different terms. The research underlying it is the same.
Yeah, I think that's a great point. I hope we'll continue to
It's-
discuss that.
But it's just, again,
Yes.
I have to talk to you if you want to talk offline.
Yeah.
Yes.
Yeah.
Yeah, but it's also just, as the people are early in your research and you're thinking about applying for a K in the next year or two, like start integrate that thinking into how you're developing your questions to make sure that it's not a scramble on the back end to, retrospectively. So just my word of caution. And again, you have fantastic resources, and I'm super excited about everything. So
Thank you so much.
Yeah, I just want to say thank you so much I don't know if you saw how many PWLE actually spoke up and asked questions because you made it accessible to everyone in the room. So I appreciate that. I'm echoing what my fellow PWLEs have shared already. But my question is, where are you planning to do recruitment for your advisory board? One of my concerns is I went here, go blue, but there's not there isn't a big sickle cell support system at the University of Michigan, which is mind blowing to me. And I've had to advocate for patients who have had sickle cell here, and I think it would be really beneficial to try to tap into that resource of individuals who may have to attend institutions that do not have support systems for sickle cell. So I was just curious how you're going to recruit for that advisory board.
Yeah, that's a great point. So I think, I really benefit from having folks like Todd on my mentorship committee to help inform the recruitment efforts. And at the same time, I don't want to depend totally on my mentors. So part of the work that I do outside of my time at work is to work with some of our community-based organizations in Georgia. We are really lucky to have 7 or 8 different community-based organizations across the state of Georgia, one of which helps to coordinate the others. So right now, my approach has been I'm reaching out to multiple different community-based organizations to help network with them, understand the work that they do and the role that they have in Georgia's community more broadly. And then that external organization that we're linking our data with is a statewide data collection initiative. So they have some pretty great relationships with community-based organizations that will be able to make sure that our reach extends past the Atlanta metro area.
Awesome. And I mean, do you know if some of these organizations are specific to rural locations, like service rural locations for folks maybe that live in Utah, that if we have a population of individuals who are Black and in a predominantly white community, if there's support systems for that, or you're going to be tapping into those community resources?
Yeah, that's a great question. So just to clarify,
thank you.
Our efforts to develop strategy are focused on Georgia because that's where we have the biggest potential for influences at the state level. So that being said, there are many rural areas in Georgia as well. There are a couple of rural hub areas, like Columbus, Georgia, for example, is a rural hub. There's a hub over closer to Savannah. So as you mentioned, when we look at statewide maps, there are definitely pockets in the middle of Georgia that are really hard to access. But my hope is that tapping into some of the close by community-based organizations and at least getting 1 or 2 representatives from them will help us to develop a recruitment strategy that is going to be able to reach folks. And the nice part about Children's Healthcare of Atlanta is, as the biggest program in the state, we have clinics that outreach to those areas, some of the areas as well.
Awesome. Thank you.
Thanks.
Fantastic presentation. I was just hoping to snag one of your references. On one of your background slides, there was a diagnosis by opioid deaths by pain diagnosis.
Mm-hmm.
Would it be okay to see that slide just one more time? Thank you.
Yeah, for sure.
Okay, thank you very much.
All right, good afternoon, everybody. My name is Scott Ravyts. I'm a clinical psychologist and assistant professor at UNC Charlotte. I'm excited to talk to you a little bit about my K12 project. So I thought I would start by just talking a little bit more broadly about my research interests. My research focuses on kind of three main areas. The first is how do trauma and adversity impact chronic pain? What are the mechanisms that might link trauma and adversity to pain? That's kind of the focus of this K12 project. And then lastly, how can psychological interventions help? And these questions really have come from my clinical work as a psychologist across a couple of different pain clinics. I think these questions are important for a variety of reasons. The first is that we know that folks with chronic pain experience disproportionately more trauma compared to people without chronic pain. We know that trauma exposure is linked with a greater likelihood of developing pain and experiencing poor pain outcomes, so higher levels of severity, worse pain interference, more widespread pain. However, trauma is not a uniform experience. It's not a checkbox. It's not limited to just ACE scores, so adverse childhood events, which some people are familiar with. There's reasons to believe that timing of stress and adversity are important and can shape health outcomes, as well as potentially what kind of traumas and adversity people experience. So more interpersonal traumas as being more problematic. Frequency is obviously important, as well as people's perceptions of what happened to them. And while we know that trauma and adversity are linked with poor health outcomes, and that might make it more difficult to cope with pain, research is less clear on how adversity and trauma might sort of get under the skin to impact pain. So that was a focus of this K12 project. And so one potential candidate linking these two things together is inflammation. We know that people who experience adversity and trauma are likely to experience higher levels of inflammation in adulthood. We know that there appears to be a dose-response relationship such that if you experience more adversity and trauma early on, that's associated with more inflammation, and that these effects can persist over time. And we see kind of a same relationship between inflammation and chronic pain. So these same inflammatory biomarkers are associated with pain and back pain specifically, which is going to be the patient population. And we see a bidirectional relationship where we believe inflammation makes pain worse, and pain also keeps driving inflammation in the future. So these stress response systems seem to be kind of similar across pain and trauma. One of the things I was interested in was whether some of these effects might happen even earlier, kind of upstream. And so one of the things we were interested in looking at is something called the conserved transcriptional response to adversity. This is basically a gene expression profile that's associated with increased inflammation, decreased antiviral response, and it's been shown to be associated with some of the key biomarkers that I talked about before that we're more familiar with in pain, as well as other poor health outcomes. There's very limited research on CTRA in chronic pain, just really limited to 2 very small pilot studies. And so the specific aims of this project were to better characterize stress and trauma exposure in adults with back pain and its relationship to pain symptoms, to examine differences in both CTRA and these inflammatory biomarkers among adults with and without back pain, and then to see if this gene expression profile and these inflammatory biomarkers link someone's lifetime stress exposure to their pain symptoms and clinical profile. And so this is a 2-part study. The first study visit's about an hour and a half, consists of some self-report questionnaires related to pain, the mental health experience and symptoms, and then something called the stress and adversity inventory. So I'll talk a little bit more about that in a second here. We did some QST, pain sensitivity testing with folks, and then did a finger prick where we collect a little bit of blood. This will be used for the CTRA analysis. And then participants are invited back about a week later to fill out a shorter questionnaire and then to do more kind of typical intravenous blood draw, where we'll use that to look at some of the more kind of traditional inflammatory biomarkers. So in terms of recruitment, this study got approved basically beginning of May. Shout out to Aaron, my PWA mentor, who helped create this recruitment poster. So we got a fair amount of interest in the study, with most individuals being eligible. Again, we were looking to recruit some patients with chronic back pain and then some without, with a heavier focus on folks with back pain. And then to date, we've recruited and tested 36 people. So again, because of our kind of recruitment focus, most of those participants to date have chronic back pain. The patient population is skewed on the younger side for reasons that I'll talk about in a second here. Predominantly female, a mix of white participants and minoritized individuals, moderate levels of pain severity and interference, and then average pain duration of 5 years, even though it's a relatively young sample. I just wanted to kind of orient people to some of the data I think will become even more interesting in the future when I have a bigger sample size and a bigger group of people without back pain. But I think one of the things that's kind of new or interesting is the use of the stress and adversity inventory, which better catalogs exposure to trauma and adversity across someone's life. So it gives you many, many data points, including kind of total lifetime stressors. So people endorsed an average of 28. Most of those were kind of moderate to high intensity stressors, and then provides a lot of data on whether this was a one-time acute stressor, chronic stressor, if it happened early or later on in life. It breaks it up into different domains, whether it's interpersonal, life-threatening, financial, et cetera, and then characterizes the type of kind of psychological experience associated with that adversity. So I think we'll get some really rich and interesting data out of this. Wanted to talk about some barriers, the next step. I'm a clinical psychologist by training, so really trying to lean and learn more about inflammations, more of the stress biology. So that was an anticipated and welcome challenge. There was more IRB challenges, mostly around kind of asking about trauma and mandated reporting. I just want to shout out, I've reached out to several people in the state of North Carolina who were very kind to me and willing to talk about some of these challenges and troubleshoot. So the pain community is really lovely in helping each other out. I think, one of the challenges and one of the strengths of the program is getting feedback from mentors and adapting the project to make it better. That does mean I did have to make some budget revisions, which I think was a challenge in terms of processing, getting equipment in time and stuff like that. And then personal training, I think, is another challenge. We needed someone with experiences of phlebotomists, coordinate timing of appointments and such. But I think we've narrowed that down now. In terms of next steps, would love to continue study recruitment and even out a little bit the two samples. Hope to do some data analysis soon on the inflammatory biomarkers and CTRA, and then hope to proceed with a K23 application that looks more at some of these new and emerging psychological interventions for pain and whether they shift not only pain, but a better understanding of the mechanisms underlying them. Just want to acknowledge this wonderful program, really blessed to be a part of it. A wonderful team of mentors, JJ, Afton, and Aaron for their expertise, kindness, and then some of the key study personnel, my graduate student, Emily, and then Chris Smith, who helps with the blood draws. So thank you.
That was a great presentation. I was just curious about, are you collecting data about diet and influence on inflammation potentially?
Yes, for sure. Diet, and then also kind of when they last ate, some sleep and circadian rhythm stuff. So things that might impact what we're seeing.
Maybe I missed this, but how is the data being separated between people for whom the trauma pre-existed the chronic pain and for whom the trauma is ongoing, as so many people with chronic pain experience ongoing medical trauma?
Yeah, that's a great question. I actually think this project might be better able to capture that in the sense that a lot of the existing data on trauma is more of a yes, no, maybe a little bit of perceptions around severity, but there's usually not a ton of questions around when things happened. And so here we both have data on frequency, severity, and then when the events happen in relation to when someone's chronic pain develops. So we can actually look and compare at pre and post, because obviously chronic pain itself is a stressor and can make other stressors worse. So I think there's some interesting data that will be there as well.
That's really cool. My second question would be, when you're in your recruitment, is there any consideration for factors like people with chronic back pain might have a larger neuroimmune axis disorder going on, and that could potentially complicate the picture of when you're testing for those inflammatory markers?
Absolutely. I try to ask questions about comorbidities and stuff to try and capture a little bit of that. But yeah, it's always tug and pull. I think Tom might have a question.
Hello, I was curious if you could talk a little bit about which treatments you're interested in, especially when you're looking at your next proposal, and how you see the data from this project potentially informing the interventions you choose.
Yeah, great question. I think I'm pulled between pain reprocessing therapy and then emotional awareness and expression therapy. For those who are less familiar with that, one is more focused maybe on hiding kind of safety, and the other one more directly takes on trauma. I think both could have an interesting impact. I mean, I think I'm leaning more towards the EAT approach because of my interest in trauma, but I think one of the kind of side projects I'm also interested in is getting perspectives from PWLEs around what are their preferences for these different traumas and what are factors that might indicate who's more likely to want what. So I'm hoping that might inform also the next steps. Yeah, thank you.
I have a question about patient burden. I'm sure Aaron has picked up on this, but you've got an hour and a half at the first visit. Have you looked at having the person with the pain do the survey at home to reduce that burden? You got like a half hour, I think, on the second visit, but I'm worried about the first one.
Yeah, absolutely. That's something Aaron and I talked about at length, and I think for some logistical reasons around the questionnaires, they couldn't necessarily be done at home, especially in terms of like an informed consent that needed to be done prior. So I think the workaround that Aaron and I talked about is, okay, it's a longer appointment, but can we mix it up in terms of the tasks? And so we kind of broke up the questionnaires into pieces. So they would do some questionnaires, some pain testing, some more questionnaires, and then the finger prick kind of blood draw. And the feedback that I've gotten from participants is that this makes it a lot more manageable and breaks it up. But yeah, absolutely something that I really wanted to think carefully around.
Thank you.
This is great, super interesting. I love hearing about when we think about trauma and pain. I'm going to give you a gentle nudge, and this is not just a call in for you. It's for a lot of folks thinking about it. When we think about trauma and stigma, and I think we talked, Jan talked about it a little bit, and I think it comes up a lot when we talk about sickle cell, for example, sickle cell disease. when we can bring in like the racism component, it comes up when we talk about other issues. We bring in, you know, the sexism and how that might impact stuff. And I know we can't use any of these words in writing grants, and they're realities, and so we should be thinking about them. Have you thought about how ableism and anti-disability stigma play into this? Because, you know, when we talk about trauma, like there's certainly ACEs and other like childhood traumas, but there's also the trauma of living in an ableist society when your body isn't working in the way that it's, quote, supposed to.
Yeah.
And especially because you had such a young sample, there's, you know, there's the whole Facebook group of like, I'm too young to be this sick. And, you know, spoonies who are talking about like, I'm 25 and I have back pain that make, you know, that I didn't think I'd have for another 60 years.
Right.
So I'm just wondering, how are you framing ableism and disability, and how are you also making sure that it's a particularly accessible environment?
Such a great question, something I've been trying to think a lot about, and I think I've tried to capture some of that experience by adding questionnaires that would reflect that, whether it's related to discrimination, there are measures in there, stigma, loneliness, and trying to capture more of the kind of social aspects of living with chronic pain. Because yes, I totally agree with you. I think we sort of have randomly decided what's sort of a big T trauma and what's a small T trauma, and I'm trying to capture a kind of more cohesive experience, including some of the things that you just described. But it's tricky.
Yeah, I think, you know, if we use Bronfenbrenner's or another model, you know, that's a social change model that looks at different levels. Macro, meso, micro is how social work often puts it. But, you know, thinking about, you know, there's the trauma that we recognize as society, but it's also traumatic living in a society that tells you your body's not right.
Yes.
So, thank you.
Thank you. Thank you.
Oh. All right, I feel like that was a big lead up to what I'm about to be talking about here. So my project is called Conquer Lupus Plus, and I will be evaluating tailored online self-management intervention to address pain interference with adults with lupus. So I'm going to talk a little bit about myself just because I haven't met many of you. So I'm a PT. I've been a PT for 20 years. It's been most of my time in clinical practice for about the first half of that. And increasingly was an orthopedic specialist, and increasingly started to see more patients with chronic pain because apparently I had the temperament, unlike some of my colleagues, to address some of the other factors that were going on. And learned I was woefully not prepared to deal with all of the factors that went into patients who had chronic pain. So went back to school to get my PhD in public health and was really interested in social determinants of health and community engaged methods, and got a faculty position at UW-Milwaukee and really started to get into epidemiology and trying to understand those social determinants, and eventually moved to Northwestern with the shift to clinical pain research, which is why I pursued the Hill K12, and eventually wanting to do more applied work, particularly in pain self-management, and then found a mentorship team that allowed me to focus on persons who are living with lupus. So in addition to being faculty at Northwestern, I also lead a dual degree PT and public health program, and my research program is largely focused on social determinants of pain, but really trying to lean into this development of pain management interventions for people at high risk for high impact chronic pain, and with my primary focus currently being on folks with lupus. So contrary to what Mohamad said, I believe I have the best mentorship team. I'm very competitive. So I have Rosalind Ramsey Goldman back there, who was in the car with me when my tire busted. And I have Yvonne, who's also part of the rheumatology team. I have Daniel Whibley, who's my pain mentor, and then I have Eden, who is my personal lived experience mentor. So I feel very well supported, and this has been one of the benefits of being a part of this program is the support that I've been receiving. So my caveat is that even though I've been in clinical practice for a very long time, my knowledge in lupus is quite limited. So I'm, you know, one of the things we say in PT is I don't recall seeing patients with lupus. That doesn't mean that they didn't see me, but that was not necessarily something that I was trained to treat. And so a big part of this first year, 6 months of the program, has been me really trying to lean into understanding the clinical presentations of lupus broadly, but specifically how that looks with respect to pain. So the caveat to that is I'm going to give you some background, but I am not an expert on the background in lupus, but this is a lot of what I've been learning. And had the benefit of reading a book that was written by someone with lived experience and had a lot of essays in there. And so trying to understand lupus from the patient perspective and from people's own words as a chronic autoimmune condition with symptoms that are a constellation of symptoms that can fluctuate in terms of their severity. And people would say things like it's a disease of self-sabotage, a roller coaster ride with your eyes closed, a baffling riddle with hidden answers, and veiled origins and misdiagnoses. And the picture is meant to reflect, as opposed to your body attacking something from the inside out, it feels as though your body's attacking it from the inside. And this really resonated with me because I have 4 children, and my youngest actually has an autoimmune condition. So as I was reading some of these stories and trying to venture to her getting a diagnosis, I was like, yeah, it felt very much like this in terms of trying to really navigate the healthcare system and find answers. So that's another reason why the lupus population has really resonated with me. And so in terms of how lupus may present visually to the people on the outside, you may see joint swelling, the butterfly rash, ulcers, some of the arthropathy, y'all know what I mean, and other swelling. So this may be how people are presenting in terms of some of their symptom presentation. And these are the things that I'm still learning a lot about, which is how lupus is attacking the body from the inside and things that could actually be measured from the physician perspective. But as a PT and someone who deals a lot with, the constellation of symptoms that may not show up with, measures with disease activity and that really have those impacts on quality of life would be things such as pain, fatigue, memory, and mental health and depression in particular. So those are the things that really resonated with me and form the foundation of the project that I'll be working on. So 65%, according to the Lupus Foundation of America, present with chronic pain as their most bothersome symptom. And so that's an area that just has not had a lot of research done in it. So that was an area that I really wanted to focus on. So was grateful to meet Dan early on in my process, who allowed me to use the Conquer Lupus website, which was developed here at University of Michigan. And we talked about that as being a baseline intervention in terms of education to provide some resources and support for people, but then adding the component of some health coaching done by physical therapists to try to improve, reduce pain interference and improve, safe progressions of physical activity. So the first phase has been to try to tailor that program, which has been a great experience. And then aim 2, which we're going to start here pretty soon, is to actually start to implement the intervention, and the primary endpoints being feasibility and acceptability, but we've got secondary endpoints related to pain and other patient-reported outcomes. So this is just a snapshot of what the Conquer Lupus website looks like. It gives a lot of information about the condition of lupus itself, some patient stories, and then also just resources on how to talk to your physician, how to do some self-care. And you can also track your progress. So a lot of self-management tools that is really going to be the foundation of the program that we'll then use for the PT coaches to really lean into in terms of providing that additional support. So where are we at? So the research strategy was finalized based on a lot of feedback from the mentorship team. The protocol's been drafted. We literally have it like, I just want to press the button to get that thing submitted, hopefully sometime this week. This is slowing me down, this conference, but that's okay. And then we've also done some of the coaching training. So me and a couple of other PTs just did that a couple weekends ago. And then we're going to start building out some manuals and things so that can be memorialized, so we can do that more systematically. What has been the evolution of it? So we started with this concept, and we really wanted to solicit diverse stakeholder feedback. Feasibility and acceptability were the primary things we wanted to look at, and we wanted to start recruitment in year 2. So in terms of where we're at, I've gotten a lot of feedback from various groups in terms of from a group focused on clinical research at Northwestern, from a group focused on physical activity at Northwestern, and then from a group focused on community engagement at Northwestern. So we've got a lot of eyes on the protocol. So It's been changed in some ways in terms of how we're thinking about some of the secondary outcomes that we want to include, and then it's pushed our recruitment back from summer to now it'll be sometime in the fall. So one of the things I wanted to highlight was the community engagement session that we did that Eden was vital in helping me prepare for in terms of Northwestern provides this as a resource for us. And so we had 9 participants, 5 of those were people living with lupus. We had some healthcare providers, 1 advocate and one researcher. And we presented the project and allowed them to offer us feedback on the protocol with focusing on a couple of the key areas that we wanted feedback on, which were our recruitment strategies, study procedures, and just some of the patient-reported outcomes. And some of the key takeaways were that we were really trying to focus, because it's a pilot, on focusing recruitment within Northwestern medicine, where we would have access to physician guidance and ability to provide support. But because of wanting to also recruit from diverse racial and ethnic populations, it was strongly recommended that we expand beyond Northwestern medicine, which may not have as big of reach into minoritized communities. So that's something we've really thought a lot about in terms of how do we create a flexible protocol that allows us to move beyond Northwestern medicine and still have that interaction with a person's physician without adding additional burden onto the person as a result of that. We also were told to raise our total compensation for our participants. So that wasn't a surprising one, but we were able to find some money to do that as well. And then also to consider how we prioritize those patient-reported outcomes. You know, we're dealing with people who are living with lupus, and while we had the common data elements, a lot of them were like, that doesn't seem relevant to like what we're experiencing. And then how do we tack on additional ones? How do we make room for that? Was a lot of what we had to think about in terms of finding outcomes that people felt good about. So that's been a lot of the work that we've been doing. So the goals for year 2, get this protocol submitted and finalized, train research staff, and still work out some of our manuals and standard operating procedures with the goal of starting recruitment, hopefully September, October, and getting at least a good year of recruitment in 2027. Towards reaching our goals, and then continuing to do, I spent a lot of time trying to lean into understanding lupus this past year, and what the heck, how do you run a clinical study? Because I've never done that before. So I want to continue to do that and continue to do some formal coursework in clinical research and also some pain science, and get some of these manuscripts submitted with respect to some of the work that we've been doing as well. So yeah, a busy year ahead. So like other people said, IRB can be a lot, especially if you've never done a clinical trial before. It's more than a notion. So there's a lot that went into that, and a lot, like sometimes we were just talking about when someone hands you a baby and they're like, here, take that home with no guidance. I felt like someone said, here's a clinical trial. Go do that. And I'm like, I don't know how to run a clinical trial. So there's been a lot of building capacity for me to really understand how to do this and try to lead other people and make them, convince them that I know what I'm doing, which is, you know, it can be a lot. And then also resolving some of these design decisions in terms of these protocol details and things changing. And as you know, you do one thing changes, there's this ripple effect throughout the protocol. And then also I have a lot of protected time, but I also have a lot of other responsibilities as core DPT faculty and director of this program. So trying to just navigate a lot of that, not to mention the whole 4-kid situation. And then just other administrative tasks that come with being a part of this program. So in terms of some wins, I have great collaborations, especially within the HEAL K12 program. And I think that's one of the best benefits of this program. Abby invited me to collaborate with her on a poster that we presented. Ryan was on there too, that we presented at USASP. She did most of the work. So I'm gonna give her props for that. It was very well done. And then I also developed an abstract with my primary mentor using some of her data from her clinical trial to try to look at some modifiable lifestyle factors in her population of folks with lupus, just to help us try to inform some of the things that we're trying to think about as we're gonna start administering my trial. And I'm also working with the other Ryan on something coming up where we just got IRB approval, and I'm working with Mark on we're the PT people. So we got our connections over here to work on improvements in DPT education. So we've got collaborations going. So that's been a big part of the work that I've been doing in the past year. So shout out to my mentorship team. They have been awesome, super supportive and guiding me. And it's been a really great experience, and it's exciting for you all, the new people, to be here. It's been a really, great program to feel like you have a lot of the support, which you don't always get when you're starting faculty positions. So thank you.
Appreciate it. I'm Tom again, and one question is, I'm sure Eden has talked to you about it. How do you cover the diversity? How do you got a very limited size for the start? It's what, 7 people? Is that, you know?
Are you talking about for the shared resource panel?
No, I guess I got that instead. For how many people are you looking?
We have a total of 60 people we're going to recruit for the pilot.
How are you going to address diversity with that kind of group?
In terms of distribution?
Yeah, age, sex, you know, locale, that kind of thing.
Yeah, we have some targets that we put in our enrollment with respect to trying to, at least within the greater Chicago area, trying to the extent that we can to try to map on or match relatively the distribution of people who are living with lupus in that area. So we have some enrollment targets that we've set, but we've also been quite realistic about it being a pilot. And some of the pilot is actually tracking that. So in terms of actually having targets, but then also trying to understand what our enrollment actually looks like using our current sources of Northwestern Medicine clinics and the Chicago Lupus registry that my mentor created to see, as we're starting to enroll folks, what does that look like so that we can get that data for like how easy or hard is it to recruit a sample that actually is diverse in terms of age, racial and ethnic diversity, et cetera. So it's both a target, but also a process-oriented thing where we're trying to understand what will that look like as we're actually starting to implement it. We're hopeful, because this is an all remote intervention, based on talking with people who are recruiting in clinic, they think that it will actually be, it will support us being able to reach a more diverse swath of people than people who are required to come in to Northwestern Medicine for in-person visits. So we're hoping that will help us reach
A follow-up question, if I
more
may.
diverse target.
How are you going to address the digital divide with the elderly in particular?
So I'm going to give you the real talk, Tom. That is part of our inclusion-exclusion criteria. So people have to be, they have to have access to internet to access the Conquer Lupus website. Outside of that, the actual coaching visits don't necessarily have to be done on a computer. They could be done over the phone. So the main thing is having access to the Conquer Lupus website. So you would have to have access to it. Internet at a minimum, or a cell phone.
I feel like we're the chatty bunch in the back. I really appreciate your honesty and authenticity about how much you're balancing and learning a whole new thing. What is it, flying a plane and putting it together as we go and all of that. I'm wondering what advice you have for the incoming, the newest group, of what they should think about as they, because you're like, I'm having to do the IRB and now the IRB is backed up and I learned about this and I'm learning about that. Any nuggets of wisdom you have as they are beginning to think through their studies, and also including, self-care and a work-life balance, because there's things like children or other people have shown their pets and surfing, right? Like how do they balance that all?
Oh, Lord. Well,
just easy, quickie question.
I think it's leaning into people who have done it before you, who give you permission to, you don't have to be, a lot of stuff's going to go wrong and you just have to be like, this is just part of it. I think leaning into people with experience, like Yvonne, some of our calls, I feel like, are largely her just being like, girl, it's not that serious. You're going to make mistakes. Don't let perfect be the enemy of good enough. So I think, some of the advice you get as early career is you're going to make some mistakes. You maybe don't know what those are, and just being okay with that in terms of self-care. I think the one thing I would say is having 75% protected time, to the extent that that's actually, respected, actually supports some more of that self-care than sometimes it can be when you are doing faculty work and having to maybe teach or do clinical. So I actually think this program actually probably is more supportive of self-care than other types of things might be. So do it now, right? Because the other stuff is coming back at a certain point, even if you do get some of the larger grants. So I think enjoy this time because you're gonna have support and time that you wouldn't otherwise have. And also don't be so hard on yourself, which is hard to do when we're all overachievers. But it's good to have people reminding you that, right, like this is, again, going to be the worst clinical trial I'll ever do, which is probably, right? Because the next one should be better, right? Like it should just always be getting better.
Thank you.